Hello, we'd like to welcome you today to our session on preparing for medication deprescribing. We have no disclosures to report with you today. We felt it is important to start with this profound quote for this presentation, as it is an art and of great importance to know when and how to taper or discontinue medications. As you can see, our learning objectives for this session are as follows. Define medication deprescribing and describe the need to plan for medication deprescribing in the remission of diabetes with lifestyle medicine treatment. Compare and contrast various methods of medication deprescribing. Analyze various patient and clinical considerations to assess in the development of medication deprescribing treatment plans. Compare the self-monitoring options available to patients and describe the role of patient self-monitoring in safe and effective medication deprescribing. Lastly, evaluate the varying classes of medications which need to be assessed for medication deprescribing with lifestyle medicine treatments. Even in traditional medicine, we should strive to never start or initiate a medication without a plan for how, when, and why it would be discontinued. Discussions should occur with patients at the point of prescribing to provide education on the treatment plan, including the reasons and situations that would lead a medication to being stopped or reduced, such as adverse drug reactions, if the medication is ineffective, or if the medication is no longer needed. Let's begin with our first objective by defining medication deprescribing. You can see on the slide today, medication deprescribing has been defined as the planned process of reducing or stopping medications that may no longer be of benefit or may be causing harm. The goal of medication deprescribing is to reduce medication burden or harm while improving life. Medication deprescribing or medication tapering can also be considered the process of tapering, stopping, discontinuing, or withdrawing drugs with the end goal of managing polypharmacy and also improving outcomes. While we can all agree that medication deprescribing is of paramount importance, particularly with lifestyle medicine treatments, we are left with little data, controlled studies, or evidence to guide deprescribing efforts. The few studies that are available have unfortunately not approached medication deprescribing in terms of lifestyle treatment. Correcting the underlying cause of illness or condition may impact plans for deprescribing that is different from deprescribing due to polypharmacy or advanced age concerns or medication side effects. We are opportunity rich for more research on deprescribing to be completed in conjunction with lifestyle treatments. Early efforts have begun with a survey of established lifestyle medication practitioners regarding their own deprescribing practices. This survey has been completed and was recently published. In your planning for medication deprescribing, the various elements that must be taken into consideration are intended to reduce the risk of patient harm and to sustain patient engagement and lifestyle behavior changes. As an example, if your patient with diabetes has glucose levels that are currently well controlled with medication, the urgency to deprescribe medications to prevent hypoglycemia may be higher than in a patient with diabetes who has uncontrolled glucose levels. Knowing if the patient is actually taking his or her medications will also impact your deprescribing decisions. We will talk more about self-monitoring and the treatment intensity and setting considerations in just a few slides. We would like to highlight the importance of planning for patient communication to and from the provider and care team possibly. Clear communication plans will ensure that the patient communication preferences are being followed. Does your patient prefer email versus telephone versus written communication? These are important distinctions to make in your plan. We have highlighted on this slide some of the items to consider when planning your communication strategy with deprescribing. How to taper, what to do if symptoms or adverse drug reactions occur, when assessments and follow-ups will occur, and who will be involved in the assessments, monitoring, and communications. For instance, will the patient contact you as the prescriber directly, or will you instruct your patient to contact a nurse, dietitian, or pharmacist in your clinic with information or with concerns? Let me turn things now over to Dr. Scholl as we move into a discussion about lifestyle treatment intensity and settings.
In the discussion on deprescribing, we have to talk about the intensity and the setting that lifestyle medicine is practiced. The more intense the treatment and the more controlled the environment, the greater and more immediate is the need for medication deprescribing efforts. For example, if a patient is only receiving education, the amount of deprescribing that's necessary is pretty minimal. However, if a patient is receiving education and is part of a food replacement program that can happen in a residential program or in some intensive outpatient programs, the need for prophylactic deprescribing is much higher. We'll go more into depth in this on the next slide. So there are two different types of intensity. There's therapeutic lifestyle change, which is not as intense as ITLC, which is intensive therapeutic lifestyle change. And these are generally practiced in two different settings, an outpatient setting and a residential setting. Referring back to deprescribing, the reason why we sometimes have to do this prophylactically is because most patients are so non-adherent with the current recommendations for diet, even those from the American Diabetes Association. In fact, only 11% of patients are following the recommendations on saturated fat. So when we switch patients to a whole food plant-based diet, it's like they're getting the medication their body needs for the first time. Discussing intensive therapeutic lifestyle change programs further, these occur primarily in two different settings, both a residential program and an outpatient program. Intensive therapeutic lifestyle change programs encourage drastic changes in the diet. They are immersion programs, more or less, whether they happen residentially or on the outpatient setting. Patients get a high level of support and education as they make changes. Many of these programs will have food provided either entirely or multiple times per week. There are several examples of both of these types of programs. Outpatient programs include those like the Complete Health Improvement Program or CHIP program. They also include food replacement programs like Denise and I ran together, where 3 weeks of whole food plant-based food were provided to the patient, and that covered lunch and dinner. And then there's residential programs. These can happen in a cardiac rehab setting, like the Ornish Spectrum program does. They can happen residentially, like the Pritikin program or McDougall program does, or the program that I experienced at Black Hills. Usually the outpatient programs are longer and will meet multiple times a week to get all of the education and training in. Residential programs are obviously more intense as the entire environment is controlled, as well as all of the food. These can be much shorter, 7 to 21 days in length. Diet is the most important factor in considering how to deprescribe medications. If a patient is starting with a very unhealthy diet and making a lot of changes to improve that diet, changing to a whole food plant-based diet in particular, medications will need to be deprescribed more rapidly than if their diet is already predominantly whole food plant-based. Another important consideration in a medication adjustment is the benefits of deprescribing. Hypoglycemia is the most dangerous side effect of keeping diabetic medications in place, especially those that cause hypoglycemia, like insulins and sulfonylureas. So allowing a patient to actually run slightly higher than we would typically recommend during an intensive lifestyle change program may be appropriate. However, there are other considerations. When we deprescribe insulin, it may actually help reduce a patient's hunger drive and allow them to stay on the regimen a little bit easier than if they were continuing on the insulin. There are two primary settings where intensive lifestyle change programs will run. One is in an outpatient setting, and the second is in a residential setting. The considerations for prophylactic medication adjustment differ slightly. So in the outpatient setting, there are usually two types of intensive therapeutic lifestyle change. One is where food education is provided, and patients are asked to make the changes for their diet on their own. The second is more intensive, where food is provided. In our experience, when Denise and I ran an intensive outpatient therapeutic lifestyle change program, the food was provided. And in this case, we found it best to reduce the insulins by about a third. And we stopped all oral hypoglycemic medications on day 1 of the program. This is similar to what was done by Lean and colleagues in the DIRECT trial, where patients' food was completely replaced for about 3 to 5 months after they had been newly diagnosed with diabetes. All anti-diabetic medications and all hypertensive medications were discontinued on day 1. However, none of the patients that were included in this trial were initially on insulin. A second group that made similar changes was Sarathi et al. In their intervention, they had patients make lifestyle changes alone if their A1C was less than 9, and with lifestyle changes in metformin only if their A1C was above 9. Both of these studies showed good results in diabetes reversal. When it comes to residential intensive therapeutic lifestyle change program, where all food is provided and patients are living on site and can be monitored closely, it may be best to reduce insulin by about 50% as soon as patients start the program on day 1. It is also important to consider stopping all oral hypoglycemic medications and following blood sugars daily. We will discuss this more in part 2. In an outpatient setting without a specific program, like diabetes condition management that is plant-based or part of a CHIP program, lifestyle changes are generally less intense because the patient is doing all of the education themselves and making all of the effort to change themselves. In this scenario, we found it most helpful to coach patients through setting goals for lifestyle change, establish appropriate follow-up with standards of diabetic care, 3 months if uncontrolled, 6 months if controlled, and lastly, to warn patients to notify us if they began to make intensive lifestyle changes. This last point we learned by experience. While Denise and I were working together, I had seen a 55-year-old male who had been on long-term insulin with a diagnosis of type 2 diabetes. He had noticed the book How Not to Die on our office table while he was waiting. After visiting with him, I referred him into the diabetes condition management program. On his first visit with our dietitian, before any of our structured education had begun, he stated that he was feeling funny. His blood sugar was checked and it was 37. On his own, he had made changes over the weekend, but we had not lowered any of his insulin. This is a great example of how powerful lifestyle changes can be and how we must counteract this power by lowering medications so patients are not put in a dangerous spot.
In this patient case, you can see the patient level of engagement is an important planning factor as it can have a dramatic effect on the intensity of the lifestyle treatment. Let's move on to our second learning objective as we discuss the various methods of medication deprescribing. I wish we could offer an easy button to guide your deprescribing efforts because it can become complex. Along with a lack of data and evidence to guide our efforts, we must keep in mind also medication characteristics that may alter your expected deprescribing outcomes. For instance, if a patient has a medication that is being tapered or stopped that has an interaction with another medication, whether that's oppositional or synergistic, you must consider the effect on the other medication. As an example, amiodarone may inhibit hepatic metabolism and increase the anticoagulant effects of warfarin. The dose of warfarin is typically adjusted after initiation of amiodarone to keep INR levels within goal ranges. Due to the half-life of amiodarone, you may not see the need to adjust warfarin for approximately 45 to 60 days after starting or stopping amiodarone. Your plan for follow-up and assessment duration and frequency needs to take these medication characteristics into account to prevent patient harm. Provider lack of knowledge and or expertise in regards to lifestyle medicine treatments and or medication deprescribing can lead to clinical inertia due to a lack of confidence in these areas. A lack of clinical studies and expert guidelines to direct medication deprescribing and lifestyle medicine leaves providers without these resources to assist in decision making. Busy clinic schedules also leave providers with little time to discuss lifestyle medicine treatments with patients, let alone develop and educate patients on medication deprescribing steps. The growth of digital home monitoring solutions and other diagnostic technologies continue to help lead medication deprescribing efforts, but does require knowledge and access to these technologies, as well as integration of the data into the electronic health record for it to be the most useful and efficient for both patients and providers. As you are deciding on a deprescribing method, some things you might want to consider, factors that are important, are patient age, comorbid conditions, and the medication characteristics, and even patient medication adherence patterns. We need to consider these in order to avoid patient harm with an adverse drug withdrawal event. It's important to watch for and know the signs to watch for that could be clinically significant that might be caused by the removal of a medication, such as symptoms like flu-like symptoms, insomnia, nausea, imbalance, and sensory disturbances that can happen when antidepressants are abruptly discontinued, leading to antidepressant discontinuation syndrome. So clinical manifestations of these adverse drug withdrawal events can include physiological withdrawal reactions, exacerbations of underlying conditions, and even new onset of symptoms. With traditional medicine, we have examples of medication classes that may be involved with adverse drug withdrawal events. We want to highlight the lack of deprescribing evidence in lifestyle treatment, and this really does impact the effect that this can have on our previous knowledge or studies. These classes of medications may not have the same level or even a withdrawal event in lifestyle medicine in the same way they do in traditional medicine. If a medication does not have a known risk for an adverse drug reaction, you can consider abrupt discontinuation. However, you might also be able to consider abrupt discontinuation with a medication known to have a risk for adverse drug reaction withdrawal, if your lifestyle treatments are actually correcting the underlying cause of the condition. This would lessen the withdrawal adverse reactions. We have referenced a study from McGowan in 2004 in this slide. In this study, they report showing no increase of cardiac events with abrupt short-term discontinuation of statins. The patients in this study, however, were not noted to be engaged in lifestyle medicine treatments. The risk for cardiac events could be even lower in patients undergoing lifestyle medicine treatments as you're correcting the hyperlipidemia with nutrition and activity. Medication tapering is another option for deprescribing when compared with abrupt discontinuation. Tapering may be used to describe the gradual reduction of either the dose or the frequency of a medication, and this could eventually lead to discontinuation. It may also be used to describe the gradual decline of one medication planned for discontinuation while you slowly increase the dose or frequency of the medication being used to replace the initial medication. The duration of tapering can be influenced by the following: medication half-life, availability of different doses or dosage forms, physiological response, patient psychological response to the tapering. Medication tapering with lifestyle treatment needs to take into consideration that cross-tapering may mean replacing a medication with a lifestyle change, not necessarily another medication. Perhaps you would consider the discontinuation of a statin with someone adopting a whole food plant-based diet to be a cross-taper and not an actual abrupt discontinuation, since we're substituting the treatment of lifestyle medicine for the medication, and we're not just stopping a medication with no other treatments on board. The other caveat with lifestyle medicine tapering is the duration and intensity of the taper could be influenced by the intensity, or we could also call that the dose, of the lifestyle treatment. We do have some examples from traditional medicine of medications where you may need to taper rather than abruptly stop the medication. However, we have to also consider that lifestyle treatment may serve as the replacement treatment and a cross taper for these classes of medications. Although this is not an example of a deprescribing algorithm for diabetes medications, we thought this tapering protocol for proton pump inhibitors would be useful to share as an example of a symptom-driven deprescribing protocol. This protocol also provides a framework for identifying which patients might be good candidates for deprescribing in comparison with patients who might not be good candidates. The protocol provides a framework for follow-up to further de-escalate or deprescribe medications and or dosages of medications. This protocol is based upon traditional medicine treatment, which may need to be adjusted for a patient engaged in intensive lifestyle treatment. Educating patients regarding the potential side effects associated with long-term medication use can be used as a stimulus for lifestyle change and medication deprescribing. Now let's move on to our third learning objective. In this slide, we'd like to describe medication deprescribing as a fine balance of competing considerations when planning where to begin medication deprescribing efforts. This is especially true when there are multiple medications that may need to be deprescribed, abruptly stopped, tapered. So you can see there's a lot of different competing factors here on the slide, and these can all influence your decision and your plan of when and where to start with deprescribing.
Financial considerations are important for a variety of reasons and stakeholders. We want to keep our patients engaged, and we're asking them to make lifestyle changes that are not always easy, but are powerful. We need to consider what is important to the patient, which for some will be finances and the cost of medications. We would like to demonstrate the value of lifestyle medicines, so it's a good idea to keep track of the money or cost saved for a patient or health plan or an employer with the medication deprescribing efforts. When we assess financial concerns, it is important to know how expensive some medications can be. You can find estimated medication costs in Table 9.3 of the ADA Standards of Medical Care for 2022. When we are developing a deprescribing plan, we need to identify how a patient's current supply, medication packaging, or formulations might impact the cost. These considerations impact your dose flexibility. As an example, you may need to send a new prescription if a strength is not available for the medication the patient is currently on, or if the dosage formulation cannot be split for a reduced dose. Another example would be a patient that's currently taking a combination medication, such as a medication that contains both sitagliptin and metformin combined into one tablet. You may have to send prescriptions for these two medications separately rather than continuing the combination tablet in your efforts to deprescribe. This could present an additional cost as the patient would be paying for two different medications, which could be an additional copay compared to the combined formulation. Other stakeholders interested in reducing the cost of diabetes, such as health plans and employers. Reducing the cost to our healthcare system should be a goal. Diabetes is the 7th leading cause of death in the United States, claiming over 282,000 lives each year, and costs $327 billion in direct medical cost and reduced productivity each year. As noted in the DIRECT trial, approximately 10% of total healthcare budgets worldwide are spent on treating diabetes and its complications, and budgets are increasing globally because of aging populations and more expensive second-line medications.
Just as important as financial considerations is taking into account our patient's goals and wishes. These may or may not be financially driven, and we have to know the patient's goals, because meeting their goals will increase the likelihood that we can continue to keep them engaged so that they sustain and possibly even expand their level of lifestyle change. So you can see for some patients, the cost of the medication may not be as important as the pill burden. So if a patient's taking 15 medications a day and they can get rid of 2 medications or 3 medications at first that might be lower cost, that might be what's more motivating to a patient than saving money. I'm going to hand things back over to Jenny now to discuss the clinical considerations.
There are many clinical considerations to take into account when deprescribing. The first is symptom control. Is the patient starting lifestyle medicine treatment with controlled hyperglycemia or uncontrolled? Why does this matter? If they are already controlled and they're getting ready to start a whole food plant-based diet, we're going to need to taper down their medications faster than someone who is very uncontrolled. Next, has the patient experienced symptomatic episodes of hypoglycemia? Again, the biggest danger in not deprescribing is hypoglycemia. So you want to see what your patient's current blood sugar levels are running at as an average, but really, what are their lowest blood sugars? If they are having blood sugars in the 50s and 60s, this is very dangerous, and you'll want to deprescribe medications quickly. Some patients will get a pseudohypoglycemia. They may have been running high for many years, and now that they're making changes, they start to get classic symptoms of hypoglycemia, feeling shaky, weak. The way to treat it is still the same as you would a true hypoglycemic episodes, with eating a little bit of food and rechecking your blood sugar shortly after. Some patients will get this even when their blood sugars are in the 100s because they have been running high for so long. This is less dangerous, but is also very disconcerting to patients. So to provide reassurance here. Next, is their blood pressure controlled prior to starting lifestyle treatments? If their blood pressure is controlled and they're on several antihypertensives, it may be time to discuss stopping one before they begin their lifestyle medicine treatments. If their blood pressure is controlled and they're not on any medications, usually their blood pressure will do just fine as they switch. So it's really looking at patients that have medications that will lower these states even further. So medication interactions. Proton pump inhibitors, for example, will reduce the bioavailability of Plavix. So what we're looking at is, as patients are starting lifestyle changes, are they going to be on groups of medications that are going to interact? And will certain foods in particular affect some of the function of their medications? Do those need to be adjusted? Primarily, we'll see this with Coumadin. And then medication adverse reactions. So some medications in diabetes actually slow the digestion of food down, and it would prevent patients from eating larger amounts of food. And then this could affect what their blood sugars could be, could affect the actual therapy that we're giving them with a lot of fiber. So if patients are on GLP-1s in particular, we may want to discuss discontinuing those so patients feel comfortable without the nausea and vomiting to eat as much food as they need to on a whole food plant-based diet. Other considerations, are patients on combination medications? If they are, do these need to be split so one could be tapered off before the other? Is there a way to do a lower dose of the combination medication? And that gets us into the next slide. Are there medications that patients are on with limited strengths, where you can only give them an injection of this amount before having to discontinue it? And so, again, these are discussions with patients, taking a look at their compliance, taking a look at ease of use for them, and then safety. Of course, anything that would cause hypoglycemia is what you want to taper down first and foremost.
Patient safety is something that we continually have to take into account. Timely adjustments to medications are important for the prevention of patient harm that can be caused from things such as hypoglycemia and hypotension. Medications used to treat diabetes that are prone to cause hypoglycemia at a higher rate are insulin, sulfonylureas, and glutamides. One of the ways that we can keep our patients safe is to be proactive in education and inspiring our patients to be self-monitoring so that we can prevent patient harm. We'll now be moving into our fourth objective, and we're going to talk a lot about self-monitoring and the importance of self-monitoring and some of the newer self-monitoring opportunities in the market. So when you're looking at self-monitoring, there's just a lot of questions we need to be asking. Does the patient currently self-monitor? Do they even know what blood glucose ranges they should be shooting for in their goals with pre-meal and post-meal? Are there any obstacles to testing? Do they have a fear or discomfort with use of needles? Does either the burden of testing with travel or work, knowing that other people might know what they're doing when they're testing and that they have diabetes, is that preventing them from self-monitoring? Sometimes it's just that patient not knowing the importance of self-monitoring and how this could really help to keep them safe, but also could really help the patient understand a lot about lifestyle medicine treatments and the impact those have. The other thing to start to ask questions about is the patient's benefit coverage. You might need some help from the members on your team here to be able to identify. You might even need to reach out to a local pharmacy to help get these questions answered. You can ask your patients also to call their insurance benefit coverage folks, but it is important to know what the coverage looks like and if something's just covered or not, but also, is there a limitation to the amount? For instance, with Medicare, there's a restriction to 1 test strip per day for patients on oral medications for diabetes. And if coverage does exist, do you need to write a prescription for that patient to allow for more frequent testing that could be beneficial during intensive lifestyle treatments? There's a lot of different technologies, and this market really seems to be evolving at a pretty fast pace when we look at glucose self-monitoring particularly. So most of us are pretty familiar with finger stick glucometers. There are some advantages and disadvantages. Patients can get them over the counter And there are some models that are relatively inexpensive if this is not covered by their benefit plan. However, it does require a finger stick with each test, and it requires the patient carry that device and those supplies with them. This also can mean that someone else would know what they're doing, even if they slip into a bathroom to test during a busy workday. Continuous glucose monitors have traditionally been used for our patients with type 1 diabetes. And sometimes more recently, you might see coverage in patients with type 2 diabetes that are not well controlled or have frequent hyperglycemia or frequent hypoglycemia episodes. For the continuous glucometers, the advantages are that finger sticks are not required, and that's even changed in the last year to 6 months. There's less and less requirement for the finger sticks or the warming up periods for these devices. So you can get multiple data points and not just that one period in time when the patient is testing with a finger stick. Really, the only time with a continuous glucometer that you have to worry about doing a finger stick is if the patient has a low that is falling pretty rapidly or too low for the continuous glucose monitor to measure, or if the patient has seen an alert on the continuous glucose monitor that might indicate a malfunction. The disadvantage is this does require prescription, and there might be coverage restrictions that could apply. For instance, some plans may not cover in any situation a continuous glucose monitor for a patient with type 2 diabetes. Blood pressure self-monitoring, also lots of technology and changes. I mean, in this day and age, you can actually go into Best Buy, an electronic store, and buy a blood pressure self-monitoring system that will download to your computer. You might even be able to use it with your phone. So again, these technologies are evolving pretty rapidly. These also are being enhanced with data capture and sharing. So these affect not just the patient and their personal use of the applications, but you might also see data capture and sharing technologies that are available for the professional or clinic applications. So a patient could be testing with a certain device that is cloud-based, and if you have a clinic code, that patient information can actually be captured from the cloud by your EMR and directly input into your patient record without the patient having to send it to you and without someone from your clinic having to upload it into the chart. So again, big changes with the technology with self-monitoring that continue to happen. There have been a couple of important advancements in glucose monitors in the last few years that I wanted to call out because they've been very important for my practice. I have witnessed patients that have been empowered and inspired by having the ability to watch and see the impact of their lifestyle changes on their glucose results as they're able to see their glucose levels over a 24-hour period of time with continuous glucose monitors. I've actually had patients who were not initially interested in lifestyle change and somewhat resistant to the conversation. Once these patients put on these continuous glucose monitors, something changes. They can see how their own glucose levels change with varying lifestyle behaviors and decisions. They can see the rise and the fall of their glucose levels all day long, rather than just capturing one level from one point in time in their day. I've heard this related to using your GPS to direct you from point A to point B. If you only turned on your GPS for 30 seconds, 1 to 3 times during a 24-hour road trip, could you actually still find your way? With a continuous glucose monitor, patients have a GPS to help them navigate lifestyle choices that are impacting their blood sugar control throughout each and every day. Identifying those things that have an effect on their blood sugar can be a powerful tool in convincing patients to move forward with lifestyle change. When talking about these advancements, I'd like to refer back to the information we discussed in the previous slide. We reviewed that traditional glucose monitors were covered nearly exclusively by medical insurance coverage. There are few continuous glucose monitors currently on the market that are covered through prescription insurance coverage now. The availability through pharmacies can open up opportunities for discount programs if pharmacy benefit coverage is either something the patient doesn't have or if the plan design doesn't include these systems. The availability through pharmacies over medical chains of distribution have reduced roadblocks that patients previously faced to getting these systems into their hands and being able to use them. Patients with type 2 diabetes have been previously unable to get coverage for these devices on many plans, as most only cover patients with type 1 diabetes. Coverage may also now be available to patients no matter what medication or medications they're using for the treatment of their diabetes.
where in the past that this may have been restricted to covering the patients that were considered insulin dependent only. Getting these systems into the hands of your patients will empower them. There are now a few of these systems, as I said, covered by pharmacy benefit coverage. These options are externally worn, so outside of the skin, applied by patients at home. They're very simple for the patients to be able to do this. And there's videos on the manufacturer's websites to walk the patients through this. I don't even typically have to have patients come in to teach them how. Once they watch the video, they feel comfortable doing it themselves at home. Sensors are typically either worn on the upper outer arm or in the abdomen area. This is decided on depending on the device manufacturer settings. And typically they're worn for 10 to 14 days at a time. We could see the length of time continue to change in the future, though, as for future studies and new products enter the market. With these new systems, patients may be able to use a smartphone application as the reader or receiver device that's actually capturing the glucose data. Older continuous glucose monitoring systems require patients to use a separate reader or receiver device, so it's just another burden, something else that they'd have to remember to bring with them, take with them wherever they were going. Continuous glucose monitors are either termed currently real-time or intermittent flash technology. And the difference really is the real-time systems push the data to the patient, while the intermittent flash systems hold several hours of memory in the sensor, but require the patient to take an action to scan the sensor to retrieve this data. These devices don't come with the same level of burden for patients that was traditionally associated or has been associated with finger stick testing. They don't have to carry supplies around with them. They're not having to stick their fingers. You know, another interesting thing that I've witnessed is patients are no longer inhibited to test their blood sugar at work or in public because the sensors aren't available to those around them. No one knows they're checking their blood sugar. No one can identify that they have diabetes because they don't see the patient doing a finger stick. I've had at least one patient say to me, "Where was this option 20 years ago? This has been life-changing for me." And as a reminder, these are carried and dispensed in most pharmacies now. The other option that's new and approved just a little over a year ago here in the US is an implantable glucose monitor. This is implanted during an office procedure in the clinic. Unlike the patients being able to self-apply the externally worn sensors, this does require an office visit for this procedure. This is currently approved in the US to be worn for 3 months at a time, and it is placed just under the skin. And there's another device that's worn on the outside of the skin that retrieves the glucose data via Bluetooth connection with the implanted monitoring device. The external device can be easily taken off, put back on during showering, swimming, and other short periods of time without losing the glucose data, because again, there's a memory there. Due to the need, though, for the office procedure to place it and remove it, the coverage here would be only through medical, and this may be more cost prohibitive, and there might be more restrictions on what medications you have to be on and which indications are covered, for as example, type 1 versus type 2. So this I would expect would be currently covered for type 1 patients almost exclusively.
So again, as I've said in the last few slides, I've really seen patients empowered and engaged when they're able to see their numbers and see the way that the lifestyle changes have been able to affect their numbers. So we also teach patients to monitor in new ways. So traditionally, with diabetes education, you'll see patients taught to either test first thing in the morning when they get up, which we call a fasting blood sugar. You might see them taught to test right before a meal and 2 hours after the start of the meal. Sometimes they'll only test one of the other, but not both of those. So what if we asked a patient to test their blood sugar after a good night's sleep versus a poor night's sleep, and they can then compare the effect that good night's sleep had, that quality of sleep, that length of sleep has on reducing their blood sugars. And then how about the way that we do the before and after a meal? What if we also taught patients to test right before and an hour after engaging in physical activity? Even if that activity is only 10 minutes of walking, for a patient to see the power of a 10-minute walk or a 30-minute walk can be transformative. So patient safety is also where we can really want to make sure we're empowering the patients and educating them. We want them to know the dangers of hypoglycemia. We want to make sure we're educating the patients on the signs and symptoms and making sure they test accordingly. We also want to make sure they know how to appropriately treat and report to you any blood glucose levels that are less than 70 milligrams per deciliter. It's really important, that reporting piece, because you want to make sure that they're telling you if they've had a low so that you can be timely adjusting the medications and continuing to taper or abruptly discontinue medications that are causing those low blood sugars. You want to make sure when you're reviewing the blood sugar logs provided by patients that you are looking for those episodes of hypoglycemia, just in case your patients are not telling you about those. Now we're going to move into our last objective, and we're going to talk about some other medications and classes of medications that need to be assessed. So when we look at reversing diabetes, the changes that we make with lifestyle treatments and behaviors, whether that's nutrition or exercise or sleep and other lifestyle treatments, are not just affecting the cause of diabetes, but it's also related to the cause of some underlying comorbidities. And it's also related to diabetes advancing and causing other complications. So as we look at the changes that we make, there's not a different diet that you would be on or a different nutritional plan that you'd be on to control depression or to reverse hypertension than it is to reverse diabetes. So that's a good thing. The changes that you're prescribing for reversing diabetes are also going to impact comorbidities such as cardiovascular disease. So we could be looking at not only needing to reverse the medications for diabetes, but also needing to reverse or deprescribe medications for statins, beta blockers, diuretics, ACE inhibitors, ARBs, calcium channel blockers, nitrates, and aspirin. Similarly, we also would be looking at medications for other complications and comorbidities such as neuropathy, nephropathy, depression, anxiety, and thyroid dysfunction. So some other categories unrelated to that don't usually come in a cluster with diabetes are acid reflux medications, allergy medications, pain medications, some vitamins, supplements, and even some homeopathic remedies. We also have to consider, besides the medications that we need to deprescribe because they might no longer be needed, they might be causing harm, we also need to be looking at deprescribing medications that can impede a patient's progress with intensive lifestyle treatment. There are categories of medications that can cause some side effects that might prevent your patients from being able to eat enough volume of food with a whole food plant-based diet. There might be weight loss medications that we need to consider taking patients off of. There might be medications that have a side effect of either hyperglycemia or hypoglycemia unawareness. So this is really just a good stopping point for us in today's module. We're going to pick up with this part of the program as we begin Module 2.
In summary today, we have defined medication deprescribing.
We'd like to thank